Thank you, son. You know, we're family here, and my task today is very simple, and that is to try to facilitate this closing plenary panel where we are going to try and put some concrete examples and language around this issue of health equity. Let me say at the very beginning that NACCHO is really one of the leading, in fact, I think, the most advanced organization in public health that thinks about health equity. And if you have not carefully looked at the tools that your organization has created for you, you need to. You need to look at the roots of inequality, the web-based course. We used it in our health department. Look at it carefully. Start using it with your staff. You need to be aware of the recent publication that really talks about expanding the boundaries of how we think about health equity. And pay attention and read the two publications, one older book and one more recent book of essays that really addresses health equity in the American context. So there are resources there, and I know we're all proud of them, but I suspect a lot of the health departments, if you have them, they're on the shelf. Take them off the shelf and look at them. Because one of the things that happens at NACCHO annual meetings is that we spend a lot of appropriate time sharing with each other concretely what we do in our health departments. And that's what my speakers are going to do. And I forgot to invite them up. Why don't you all come up while I do this introduction? And so what I want to do for just a few minutes is set some framework, set some scaffolding around which my colleagues are going to speak. And in case you haven't figured it out yet, this is a secret agenda for next year in Phoenix, where we're going to spend a lot of time looking at health equity. Now, some of you younger people may think that health equity is new. Well, it's not. We may change the jargon around which we talk about health problems, but this is not a new issue. And for those of you who have been formally trained in one of our programs in the past several decades, you may even have heard the term social determinants of health thrown around. But do we really think about what that means? And are we really serious about addressing those social determinants of health? I'm telling you, no, we're not. We're not serious, and we don't think about what it means. The social determinants of health are the intermediary factors that complicate how people can stay healthy. We are so often focused on our individual level interventions that too often we do forget about the social determinants of health. But if we look at the social determinants of health, for now till next century, we will never solve the problem of health inequity. Because health and disease are determined by structural conditions that we create as human beings, not influenced, determined by how our government works or doesn't work. Whether or not we have paid sick days, that's a governmental policy. What kind of labor laws do we have? What kind of economic structure do we have? Do we have a government where equality is at the basis of its functioning? Or do we have a government that places in law segregated housing, which is what our federal government did in the 20s and 30s, and it's still with us today? So we have to remember our history. This is not a new topic. It's not an extra topic. It's not yet another box that you have to check off on what a local health department does. If you feel like it, you feel overwhelmed. But that's not what it is. Social justice and health equity are at the core, the foundational layer of what we do in public health. Public health has always been tied to social movements in the United States of America. And at those moments in history where we are most closely aligned with social movements, we make the most progress. And at those times in history when we become technical academic, bureaucrats, we lose staff, we lose programs, and we have more separation between ourselves and the communities that we're privileged to serve. So when we think about what health equity is really about, it's about creating permanent alliances with social movements. How can we address childhood obesity in the city of Chicago, where I live, when we close down 50 schools? You can't do it. How can we address childhood obesity when they lay off all the gym teachers and eliminate recess? You can't do it. How can we address childhood obesity when they cut food stamp programs? And while you may not know it, if you talk to our nutritionists, they explain to me, dollar for calorie, Red Hots and a pop will get you more calories for those pennies if all you got is pennies. Think about it. During this conference, we've had some profound discussions on health equity, but I'm not sure we all caught it because the words weren't used. Now, you know, Illinois is right next to Indiana. Now, I'm going to tell you, all of us have biases. I'm a city girl. I'm a northern city girl. That's what I am, okay? I do not pay careful attention to what goes on in southern Indiana. But that story about Scott County, which I did pay attention to and know something that stuff wasn't said, but you know, some people are more polite than me, so that's okay. Think about that. Was really an example of health inequity in all of its aspects. What reasonable person in this audience would say that 3.5 staff is adequate to protect the health of even a small county like Scott County? More importantly, I live in Chicago. I know in rural Illinois and rural Ohio and Kansas and Nebraska and Wisconsin and Michigan and Indiana, IV opiate use is skyrocketing in our rural communities, in our small towns among white working class folks. You see, on the south side of Chicago in Inglewood, we know a heroin addict when we see it. You know, I know what to do. I've been in shooting galleries before. I know it may be a new phenomenon for some people. Okay? So think about what this means. A state that decides by policy that government is not important. Think about what that says. A state that says, we don't have to fund this. We can have a county with 3.5 public health people. We don't have to pay attention to the economic oppression of that 97% white county. We don't care that they're unemployed. We don't care that they're hopeless. If they'd come up to Inglewood and stopped anybody on the corner, they would tell you what happens when you have that situation. And for those of you who may not know too much about Indiana, way far north, near Chicago, is a city called Gary. You think there wasn't HIV there? You think there weren't IV drug users there? This is what happens when we silo our concerns and expectations by class and race and gender and fail to understand the underlying structural factors that connect these things together. We need to be clear that the predominant way we distribute resources in this country, the predominant, not the only way, but the predominant ways are by class, by race and ethnicity, and by gender. And if we want to create conditions that allow people to be healthy, we have to go to community organizing. This is what we've always done. What do you think visiting nurses did when they went knocking on those doors? They weren't just passing out health information, and they knew what they were doing. Community organizing is a basic tool that social workers, public health people, and rabble-rousers have used forever. If we were connected to our communities, if we were doing real active surveillance, we would keep track of foreclosures. We would know when IV drug use was go up. These police crimes, I want to be clear. I'm an old doctor in an urban setting, so I've worked with police for decades. You work with them in emergency rooms. If you're an old rabble-rouser like me, for those of you that may be young rabble-rousers, if you have a demonstration, always contact the police first. You talk to the police, right, sister? You talk to the police ahead of time. You always have to work with the police because they have guns. So I don't want you to misunderstand what I'm about to tell you. Okay. I know many policemen of all races and ethnicities. But I am a mother of a black man. Come on now, see, some of you didn't say nothing. Let me go back and let me try to bring you along. It's a lot of mothers here, right? Yes. I'm not putting down the daddies now. It's a lot of mothers here. Think about how you feel about your child, the hopes you have for your child, the fears you have for your child, and understand the terror that black mothers feel when their little boys are growing to be men. The pure terror when a Friday night they're 2 minutes late getting in from their party. I can't adequately, I still have PSTD. I'm in post-traumatic stress myself. My son is 44, I'm still having it. Because the police authority, now listen carefully, I'm not talking about every single individual policeman. The police authority is put there to oppress my sons and daughters. How does a 230-pound grown man with a gun fear for his life from a 16-year-old? Only if you don't think they're human. Only if you think they're an animal. Only if you think they're only worth what a dog is worth. And if we're not out in the community talking with the youth, talking with all the neighbors, talking with the police, we're in trouble. We fail to recognize the terror that exists. It's critical that our health departments talk about health equity and consciously work on health equity. Why? Because we're losing budgets and we're losing staff. What's the relationship? The health of the public depends on what we in governmental public health do. Non-governmental public health is important. I'm not putting them down. But the role of government is central to the health of a population. That's what decides whether you have libraries and schools or whether you have prisons. I often say that everything is public health, and many of my learned comrades in public health say, Linda, if you say that, that means nothing is public health. I said, no. Everything is public health because the one outcome that everybody wants, I don't care if you're in rural Mississippi flying the Confederate flag or in Inglewood in Chicago, the one outcome that everybody wants for themselves and their family is health and well-being. This is our ultimate outcome goal. And there's only one way I know of to achieve that goal. That's by having enough education and knowledge to be able to fight for the power that we need to guarantee a democracy, because it's only with democracy that we have some hope of changing those structural factors that decide whether we will be sick or healthy. So what we're going to do now is talk about an initiative that your organization launched to consciously, in an informed way, bring together local public health departments with experts in community organizing and say, how can we use this critical tool of community organizing to better address health equity and guarantee that, in fact, people are healthy. We have an excellent panel, And first I'm going to bring to the podium Renee Canady. She has all I'm not going to spend all this time reading this stuff. You can read it later. You should know Renee anyway. Right now she's the CEO of the Michigan Public Health Institute. She formerly was a health officer for Ingham County Health Department. She's a medical sociologist by training. She's a fighter for justice, and I want to bring her to the table to talk about what your health equity team did in conceiving and launching this project. Renee.
Thank you, Dr. Murray, and thank you for being here. I would dare say if your steps have been ordered to this place at this time, in this moment, you're here to receive the gauntlet. If you haven't picked it up yet, your president, Dr. Jett, threw it down. Dr. Murray continued to slam it down even further. This is a drop the mic kind of a moment. So you guys stay with us. It was maybe, I don't know, Richard, what, 5, 6 years ago, when I was invited to a meeting at the Centers for Disease Control. I had the privilege of serving as the chair of NACCHO's Health Equity Social Justice Committee at the time. And they said, would you go down to this meeting and represent NACCHO? Sure. So we go down there, this meeting with community organizers. I was like, oh yeah, we do community organizing at my local health department. And I sat and listened and figured out that we don't do community organizing. Wait a minute, community organizing is a thing. I mean, I knew that President Obama had been ridiculed for being a community organizer, but I began to figure out as a public health leader that there was this tool, there was this thing with a science, a history, a methodology that we might be able to connect with to advance assuring the conditions needed for good health in this society. And so we started this journey that has been really amazing. It is how we do health equity. It's not about further describing health disparities. It is not about kind of admiring the problem or the goal of health equity. It is about how we attack not just how we deal with social determinants of health, but how do we attack social determinants of health inequity. And so I want to just throw out this model that we've used. You know, I think about this a lot as the tale of two cities. And the tyranny in this tale of two cities was really the narrative. And it's a narrative that we've allowed to stifle us in public health. It's a narrative that we've allowed to tie our hands. So when we listen to conversations, even among our leadership, those to whom we're accountable, and they say, well, you know, stay in your lane. You know, you're talking about this, you know, prisons and schools, you know, stay in your lane, and we back down. Or when we hear them say, well, that's not in your wheelhouse, now all of a sudden everything's got to be in our wheelhouse. But you heard Dr. Murray describe and you heard Dr. Jett describe, this is public health. And so we are trying to attack the narrative, reframe it and reestablish it and remind us of what we are, who we are as public health professionals. So I'm going to just click through a couple of slides because I want you to, let's see, where do y'all want me to point this? There we go. Well, my colleague Doak Bloss, who served as the Health Equity Social Justice Coordinator at Ingham, let me borrow some of his very fancy slides. And they're animated and they don't yield themselves to clicking through really quickly. But I'm going to jump really to the last one because we want you to hear the example and we want to talk with you afterwards. So we went through this whole continuum of kind of speed dating with community organizers. What exactly is community organizing? And we began to figure out that, wow, there is something that community organizers bring to the table. There's a language. There are things like one-on-ones. There's this thing called agitating. There's this thing called cutting issues. And we learned about that. And they began to learn that public health was more than data. We had relationships. we had knowledge, we had methodology, we had connections to the people they were trying to affect change with. And so we got to know each other. And then we said, okay, well, let's help each other. A little help, please. And we started talking about what we could do and what we could gain together so that we could both then transition to what we refer to as a mutual self-interest. Before public health was doing its own thing, community organizers were doing their own things. Community organizers were talking about power. It's about power. And public health, more progressive public health, was talking about, no, it's about racism. It's a history that's entrenched in othering people and devaluing sectors of our society. And so we reconciled what a power discourse looked like in the context of historical and structural racism. And we built a very deep relationship that then allowed us to think about what we could do together, both as organizers and as public health, because it is up to us. We are now at a tipping point, and I don't know where you are in your career. If you're mid-career, if you're ending your career, or if you're stepping in newly, public health, the public health that is going to assure the conditions necessary for good health is not the public health that we sit in right now. We are starting a movement, and we invite you to join us.
And we're so fortunate here to be in Kansas City, home of the second best barbecue in the country. And be hosted by a great health department. And Rex and Kathryn are going to come up as soon as I finish summarizing some introductions to them, to really give us a concrete example of things that they've done here in Kansas City to really allow us to think carefully about this relationship. As you know, Rex Archer is one of the past presidents of NACCHO. He's the director of health for the city of Kansas City, where we are. He's on the executive committee of FAB. He's played a leadership role in a whole range of our national committees. He's a medical physician by training, and he's going to come up and lead their discussion. And joining him will be Kathryn Evans, who holds a master's in public administration from the University of Missouri, and is the lead community organizers for Communities Creating Opportunities, part of our PICO national network. And they're going to describe to us some of the exciting things that have been going on here in Kansas City.
Thank you. Dr. Murray left only one important thing off the intro, and that's that I consider myself a community organizing intern, even though I've been at this for about 8 years now. There's a lot to learn. It's a very deep profession. So again, welcome to Kansas City. Next year's conference in Arizona, this session is really keying up to that, cultivating a culture of health equity. That's what it's going to be about next year in Arizona, and we hope you're going to come there also. Let's see, is this the... So the Institute of Medicine back in 1988 kind of indicted us in public health and said we were in disarray, defined that we needed to be about what we as a society do collectively to assure the conditions in which people can be healthy. And a number of folks in public health and community organizing have started to adjust this definition to say that do collectively isn't detailed enough, that it's really through organized actions or movements that we can do this work. And it's really, if you look at our 149-year history as a health department here, it was actually these social movements that we've been engaged with over time, and that we're interested in health equity of all people. Our city council now, in its 5-year business plan, actually has an objective to increase life expectancy and reduce the inequities between zip codes. So where we live shouldn't determine how long we live. As with Renee, I'm going to have extra slides that I won't spend the time on that they could have been, but they're a resource for you after the conference that you can take home for elected officials, your own staff, and you can use these slides. So I've just kind of hit some of these pretty quickly. So when we look at, and you've all seen zip code disparity maps, the pink zip code there is where our racial divide from redlining, blockbusting, all kinds of discriminatory practices that were in place, and they have substantially increased our early death there. We have a 13-year difference in life expectancy between our longest and shortest living zip codes. When we look at those shortest and longest living zip codes across the board on what gets put on a death certificate, I won't call that a cause of death though, I think those are symptoms. But if we eliminated cancer, all the 100 forms of cancer tomorrow, it wouldn't really change anything because the root causes are increasing all of these. You can see that for every factor there, it's about twice as high in those income in those zip codes. With one exception, which is homicides, and it's 20 times as high. And in fact, we're coming to believe in Kansas City that the violence and the homicides is actually a root cause that's increasing the risk of all these other factors. We've all seen life expectancy improvements. For all 4 of our largest major groups, we've had improvement over the last 10, 15 years, white females and black females, white and black males. And the slight good news is that the gap is slowly closing. But at the rate of gap, we're going to be around for another 100 years before we have it closed unless we accelerate that and do something different. So we've taken Galia's work at the estimated number of deaths from these social factors US-wide. One of our staff members had a poster session on this also. And you'll see that 47% of our deaths each year in Kansas City, Missouri are due to these 6 factors. How many of you believe that 47% of my budget is spent on these 6 factors? Obviously, we've got a lot of work to do. Plus, we actually don't have the skill set to work in a lot of these areas, and that's where we need to be partnering with community organizers. So just again, proportionately, if the social and economic factors are 4 to 5 times as important as clinical care, then we need to be thinking about what we're doing and doing it differently. I love this slide because you look at all the sick things in that tree on the left, and you think about all the effort that we put into those activities, and we sometimes are categorically funded. But it's the roots down there, and I know that it's kind of an eye test for you to see, but again, you can get access to these slides after the conference. And unless we're working on those root causes of these problems in our communities, we're not going to have a healthy tree. So it really is the community organizing techniques that helps us to create a healthy community and deal with those issues. The Bay Area Health Equities Initiative also looks at this medical and social model, and we've all heard the river parable where we're out there and there are kids and folks drowning and we're helping them, and we go around the bend to figure out who's throwing them in, and then we go around the next bend, find out a little bit more, and we go around the next bend. And so with this diagram, you can really go through with your community and talk about each of these bends. As you move over to the left on the socio-ecological model, you have all the place matter issues, all the social inequities in our neighborhoods and our workplaces. Why are those there? You know, how many of you have had kids that keep asking why? Or quality improvement, there's the 5 whys to get to root causes. Well, it's because our institutional powers permit and or have actually caused and contribute to those social inequities. And then we ask, why do those things do that? It's because of all of our discriminatory beliefs, all of our isms. So ultimately, we actually have to work with our community organizers to change the whole narrative of how we look at our factors in our country. So these are health disparities. I don't even use that term anymore because really it's health inequities or injustices. And then another way of picturing this is many of us are trained on the right side there under disease and risk management. But as we move into democratic self-governance, that it matters. If you ask me what are some of the top priorities for Kansas City, well, it's voter registration in the urban core. If those folks aren't engaged in voting, they're not counted by elected officials. And so we have at least 10 areas that we think about that are social determinants of health that you can be working in these areas. And different ones get a movement moving, as was mentioned. If you see a movement starting in this area, contribute to it, work with it, help those folks mobilize, because any of these can make a difference in your community and they interact. I'm going to turn this over to Kathryn at this time, but I want to just say that when you're partnering with other organizations, it's often good to look at where do you have shared values, because if you have shared values, then you can communicate and you can work through miscommunication and differences in cultures and all of that. So we've identified shared values that we have between community organizers in Kansas City and our health department, and that's helped us a long ways. Over the last 7, 8 years, it's moved from I have in my action plan and my work plan each year to work with community organizers. That's part of what my boss understands that I know I need to be doing. We have 10 community organizers basically in our suite in our health department. That's a not-for-profit, so it's like almost a division, but not a division of the health department that is working with us on these kinds of issues. We have a memorandum of understanding. We actually fund each other at different times on different projects where we come together and pursue grants together and work together. And we're out there and we march with each other on different kinds of social movement issues. So with that, Kathryn, I want to come up and take us home. Oh, one more quick ad. There's a great resource called Faith-Rooted Organizing. And it's just one of the ways of learning more about how you can work with your faith communities and other types of organizers.
Thank you. Thank you, Dr. Archer. So as it was mentioned earlier, I am a community organizer. I was at one time a professional organizer. I was trained in the field of organizing by the PICO National Network for 3 years. And I've recently moved on to being in community research and planning, but I will always be an organizer, and so I'm really grateful to be here today. I'm not going to give you a course on organizing like Renee was talking about. I'm not going to give you an organizing 101. I hope that that's homework that you do when you go back home. What I am here to do is to help you get really clear about what it takes and what we're up against in the fight for health equity. And not just health equity, but equity in all aspects of human life. So you already know that what determines health is not about behaviors, not just about behaviors or genetics. It's the environment you live in, your situatedness, where you're kind of located in the fabric of society. And I want to talk to you today about that fabric. I want to talk to you about some of the factors, some of the values even that make up our society and cause health inequity. Some of those threads include racism, capitalism, patriarchy, white supremacy, imperialism, privilege. How many of you got a little uncomfortable with those words? Raise your hand. We're all family here. I think you should settle in, because even though these aren't feel-good words, they are realities of what creates inequity in our communities, and they're factors that we really have to grapple with in public health. Another word that might make you a little antsy is power. We've said it a few times up here. Too often people equate power, this idea of power, with greed or control. How many of you have that association with the word power? I know I did. Let me see those hands. Okay, there we go. Power is critical. Understanding what it is and who has it and who needs it and how it's used It's critical not just in organizing, but in the field of public health as well. I'm not interested in the kind of power that is about greed and control, and I don't think you are either, but what I am interested in is the full participation and inclusion and transparency in accountability in all decision-making in all systems, public and private. And what is required in order to get those kind of systems and those kinds of processes is power. It's the ability for people to act and to have agency in their lives. So community organizing really is about radically transforming oppressive systems that exclude and marginalize and exploit particular groups, and to do so in such a way that everyone has a say and everyone is a part of the pattern of decisions that determines health and well-being. Is this making sense? Great. So this idea of power, so I grew up in the Catholic Church in the South. So as a woman, a black woman in this context, power never had positive associations for me. When I started organizing, I realized immediately that I had to let go of those hang-ups about power. When I first started organizing, I encountered a woman named Sandra. Sandra is a Kansas City resident. She's in her mid-30s, a white woman, mother of 3 gorgeous children. And Sandra and I formed a friendship over the course of several months. And she came to me one day asking me for help because she kept running out of money at the end of every month. And she couldn't figure out why. She couldn't figure out where her money was going. So she asked me to help her with a budget. And I sat down with Sandra, and I wrote down her budget items line by line. And we got to the end, and she said, don't forget to add the $200 for my payday loan. And I kind of looked at her and I said, wow, that's a lot of money to pay back for a loan every month. How much did you take out? And she told me she had taken out $500. So Sandra took out a $500 loan. At this point, it was probably 4 or 5 months ago, and she was still paying $200 every single month to get this loan repaid. And I couldn't believe it. I asked her to bring me her contract that she had signed, and when I looked at it, I saw that the interest rate was 450%. So I was just as outraged as you probably are, and as I started to dig a little bit more and ask this question of why, which is a really critical question to keep peeling back the layers of why, I started to learn more about this payday industry and how much power it had. And I started to ask questions like, why does this industry have so much power? And I learned that in the state of Missouri, because of the no limits on campaign finance and no limits on lobbying, the payday industry had managed to gain a foothold in the legislature and totally blocked any legislation capping interest rates on payday loans. So here we have this huge system that is validated by our legislative system that is keeping people like Sandra completely powerless. And it was clear to me that even though Sandra means a lot to me and I love her very much, she has no value beyond what she can contribute to the bottom line of these payday companies. She has no value to them. And the commodification of people is a very real problem. It's a real challenge, and I would argue probably the greatest challenge that we're facing in public health. The fact that profits are more important than people, and as long as that's the truth, we're going to keep having to go upstream. So it's really important for you in your own context to get clear about who's benefiting from the issues that you're witnessing in your community, and to be constantly asking that question of why and how is that happening? And it matters that we know that. It matters because it changes our strategy, it informs our strategy, it informs how we approach things, right? And you know, I think one of the core values of organizing in the PICO network is we only have as much justice as we have the power to compel. So if we're seeking justice, but we don't have the power to transform the systems of injustice, we're not going to get there. So I'm sure some of you are asking, what the heck does this have to do with public health? It has everything to do with public health. I think another thing that I kind of want to leave you with is, I'm not going to try to define power for you. I mean, there's a lot of definitions of power, but I kind of want to get you a sense of what it looks like. So I think of power as sort of 3 buckets: organized people, organized money, and organized ideas. And I'm going to spend just a little bit of time breaking that down for you. So I'm going to start with money because, let's be real, we live in a capitalist economic system, so we gotta pay to play, right? And unfortunately, there are not many funders who are going to just fund organizing. And this is something that I encountered as an organizer who raised money for our organization. It was really hard to convince funders that their dollars were going to maybe have a 5 or 10-year return, right? And that's how long these kinds of social movements take. So, you know, the Ford Foundation, which is one of the largest foundations in this country, recently moved a lot of their dollars to funding inequality, to funding this kind of grassroots work. But it's probably not going to happen. It's that trend is probably not going to show up in your local communities for some time. So you have to get really creative about how you engage in and find resources to engage in organizing. And the way that we've done this in Kansas City is, as Dr. Archer said, our organization moved into the health department, and we share resources. We fund each other from time to time, and you just have to get really creative about your alliances and how you're resourcing them. Organized ideas. This is a really, really important one. This is about that dominant narrative. The dominant narrative about who are poor people, who are black people, who are Christian people, who are urban people. These dominant narratives, these stories that we sort of internalize from a very young age about what kind of characteristics certain groups have. I was once with a group of leaders, community leaders, and I wrote down on a flip chart a list of words like thug, feminist, terrorist. It was probably about 10 words. And I asked them to respond by saying the first thing that they thought of when they heard those words. And this was a very close room, so there was a lot of room to be honest. And when we sort of dug into where these associations came from, a lot of them come from very young age, experiences and stories that people have heard and internalized from a very young age. And that's what the dominant narrative is. It's connections between all of those different stories that we hear. And these organized ideas are really powerful, right? I mean, they're used in media and in politics and in all sorts of different venues to both distract us from what's really going on and to influence the way that we think about certain policies and certain groups of people. So we have an opportunity, I think, probably more than ever now to influence a dominant narrative given how fast media and communication moves, and we have to get really serious. You have to get really serious about what role public health is going to play in influencing the dominant narrative and transforming that. So then the final thing that I want to talk about is organized people, which is really the crux of what organizing. It's the bread and butter, the heart and soul of what we do in organizing. It is not an easy thing to do, and it takes sort of 3, I think, really key ingredients. People who know what their story is, know who they are and what they care about, people who are clear about power and how it works in their communities, and people who have a base of other people that they can bring along with them. So if you take nothing else from my comments today, I want you to take these 3 questions home with you, and feel free to write them down. What is your story as public health? What is the story of your public health department? What is the story of you as a practitioner? And what do you care about? What are your values and your beliefs? What is your bottom line? What are your non-negotiables? What are you not okay accepting? Get really clear on that. What's your analysis of power in your context, in your community? Who's running the show? Who's making decisions? And who's benefiting from people being oppressed and powerless? And then who is your base? This is a question that Richard Hofrichter always is challenging his colleagues on. Who is your base? Who are you moving? Who do you have behind you when you're ready to move on an issue? You got to get really clear on that too. I think that there's a really great opportunity here for public health and organizing to come together. We've done it in fits and starts in Kansas City. We've done trial and error, but I'm going to invite Rex back up in a minute to talk about some of our campaigns that we've done together. But I think that the opportunity really lies in the fact that there's a sort of mutual benefit, right? I mean, public health brings the institutional sort of credential, the institutional status, the data and the research and the methodology. And organizing brings that street cred. The relationships that we build with communities is really an essential part of what we're doing. And The final thing that I'll say is when you're trying to determine whether or not something is a public health issue, whether or not you should care about it or spend resources on it, the question that you need to ask yourself is, does this create conditions that threaten the health and well-being of some groups of people? And if the answer is yes, it's a public health issue and you need to be spending some time on it.
So I'm just going to forward the slide real quick if we can get it back up here, and then we'll go to questions. So when we think about justice, it comes from truth, which is often public health practice, research data, and community organizing that brings the power. These are aligned campaigns that we've been working on, and so we're going to go ahead and open up for questions on any of these campaigns or others. We've had several very important successes, some failures that we've learned from we can talk about during the Q&A.
Stand up and shout, if you will. I don't know if we have a hand mic. Oh, they're getting them in the back. Now, so let me help you all out, because you know you're at a professional conference, and you have the men, a lot of have their ties on. You look so. Don't be polite. Okay? We want to have some real discussion. I'm going to start off with two quick stories. They're in the mics over here in the aisles. So we have actually one of the leading people in our health department. James Lloyd is here. He works really hard on health equity. He has real problems in our health department. This is home, so I can say this. You know, he will involve in our work around Place Matters. He will involve ROC, which is an organization that's doing organizing of restaurant workers trying to get decent living conditions. He thinks that's part of public health. I agree. Not everybody in our department likes that. Similarly, sometimes I would go to a meeting that somebody in our health department organized, and they said, oh, we're going to have a meeting, Linda. We're going to have community people there. And I'd walk up, and there'd be three slicers. You know, slick. These people, they're hustlers. Now, maybe they don't know because they didn't live in it, but I lived in that community. I know these cats were hustlers. Now, you can't say you're hustlers, get out the meeting. But it's not easy. You know, you got to know what you're doing. Otherwise, you can get in a lot of trouble. You know, so don't be polite. Please come up to the mics, make a statement, ask a question. Let's be real about this, because one thing that is real are the conditions. Yes? Just shout.
Hey, okay, so thank you, Dr. Murray, Dr. Hasbrook, and Dr. Jett, as well as the panel. Umair Shah, Harris County, down in Houston, Texas. So I guess my real question, and I know the answer that Dr. Murray is going to get because I've had this conversation with her privately, but the question I have for the panelists is, so you've got folks in the audience that may be, I'm not sure if it's the right word, but let's say, and it may not be true either, believers. They get it, understand it, feel it, are compelled by it, et cetera. Yet there's a complete audience that's outside of this room. How much time and effort and really some of the real activities around convincing do we and do you see that our role should be, and how effectively can we do that? Thank you.
So the Healthy Heartlands, which is the title that we've given this initiative between community organizers and local public health, and it is local public health, has really been about us doing our own work across disciplines so that we can then be more effective in the outwardly facing work. And the internal work has been, I mean, we didn't just meet at a meeting and then say, hey, let's take on living wage. So it is about building a trajectory of change. There are some local health departments that have very little capacity to do this, and their community organizing entity in their community is huge and robust, and vice versa. So it is about kind of getting in where you fit in, beginning to understand the tools of both disciplines, and then framing the narrative and the strategy together.
Let me make sure I'm phrasing. What I meant was folks who don't agree, disagree, are completely against. How much, that was really the focus. Let me make sure I'm clear on my question.
We're talking about public health folks or the community or your elected officials or?
Check.
Okay.
Check.
So how did I start with this to some degree? It was a Saturday morning in 2007 when I was at a meeting way down south in the city, and I noticed that there was 4 or 5 of our council members there that stayed for 3.5 hours on a Saturday. And it was the community organizing group that had organized this meeting and got them out. And I decided, well, if they can get their attention for that period of time, I need to learn something from them. So I started spending some time with those folks. I went to a 2.5-day training with one of our other staff members at the health department. That kept evolving. I started to see that actually the roots of public health and social movements were there, that we kind of got sidetracked when antibiotics and Hilburton and hospitals got built. We got sidetracked from our core history in public health and social movements. And so that then started a process. Now, I would recommend for anybody thinking about this, don't go from 0 to 60 in 1 second. You know, the faster you move in most systems, the more resistance you'll build. So you be methodical, you think about it, you're incremental, you start to introduce the concept. You know, I put it into my work plan to explore the issue. Eventually it's in our health department's strategic plan. You know, then when the organizing group had grown and had outgrown their Catholic parish that they were at for 35 years, and they needed space, and we had an opening, it was a natural for them to move into our building. So it's been incremental at each stage of the process. And now I'm out there when they are doing demonstration marches, and I'll be marching along with them on certain causes. Now, if it's a restaurant that isn't paying the right wage, but we inspect them, then I don't do those because of that kind of check and balance. But if it's a restaurant outside of our city, I might very well be there with the community organizers marching or protesting.
It's also your responsibility as a leader to do what we've learned to describe as one-on-ones. So those ones that you know don't get it, don't want to get it, and don't agree, those are the ones that you engage. What is their self-interest? What are they motivated by? And I would say that you as public health leaders, health officers, deputy health officers, whatever your role is, that's your responsibility to start the dialogue.
Our new employee orientation, we actually have the community organizers go through with our employees, and they actually spend 15 minutes out of the 8-hour day talking about community organizing. So we actually do joint training together.
Yes.
Hi, I'm from the health department in San Antonio, and I am a community organizer that is employed by the health department. Our leadership has been very supportive in expanding our role within the health department, so now we have a staff of 25 community health workers who also serve that role first and foremost as community organizers and advocates. We've been able to partner with an outside entity who has a long history, a long tradition of organizing in San Antonio. But what we've encountered, you know, it did take us a while to build that trust with the community, coming from the city, with the organizers, coming from the city, because we have such tremendous health disparities, the city is seen as an enemy. And so I think we've gotten more pushback from within the city government structure. So that's my question. How would you encourage, well, frankly, city government not to be afraid of community and community organizers? Because that's what we've encountered. We've had elected officials who have called us into their office. What are you doing? You know, we've had a lot of pushback, but we've gotten a lot of support from the community, and we've had tremendous leadership within our health department.
Why do you think your politicians are worried?
They're scared.
and do you think they have a right to be scared?
They're used to having, I mean, I know at least in South Texas, they're used to having a disenfranchised community who's lets anything happen to them. anything done to them without, raising their voice. And historically that has happened in the past, and they've made tremendous strides, but it's never come from inside the system.
So let me add, I won't reframe it, let me add her question. If you're Rahm Emanuel in the city of Chicago, and someone comes to me and they're organizing neighborhoods to keep the schools open, why shouldn't I be afraid? And how would you convince me as a health department that you have any right to be involved in any of this?
Let me first acknowledge the truth of tension in these relationships. When I was health officer and we hired a community organizer to be our environmental justice coordinator, my community organizing colleagues in this Midwest project said, you can't hire an organizer because you are the object of which we will organize. You're the direct action that we're targeting, so you can't have an organizer. But you got to figure out each community. I mean, it is about fear, but we keep saying we are here. This is about serving the public in public health, and we are accountable to them. We've got to be transparent, and we've got to let them have some power in setting our agendas. And it might look different in my community than it does in another community, but that's the richness of this.
Jonathan Fielding said yesterday that one of the things that we all really need to think about as directors and in our health departments is who do we serve? We serve the public. I have 500,000 patients, whether they know I'm their doctor or not. Yes, I have a city manager and a mayor and city council, and most of the time they get it. And yes, I will follow orders when they come down, or if I can't live with that, then I have to leave the position. But it's a matter of, it's the people that we're there to protect. And
another way of thinking about it goes back to that question of who is your base, which is not a question that public health thinks about a lot, right? But in organizing, we are accountable as organizers. As an organizer, I'm accountable to the people that I'm organizing. I am accountable to voters. The elected officials are also accountable to voters. And so I think you have to just keep it in that context. You also have to, I think, remember that there's a lot that your leaders in your community can do that maybe you can't do in your role, but your job is to help them strategize, to agitate them, to train them and coach them so that they can step into those public roles and hold their elected officials accountable so that you don't even have to be a part of those conversations because you're training them to do it.
Yes, this Mike.
Hi, my name is Tricia Tillman. Can you hear me? Sorry. My name is Tricia Tillman, and I am the Public Health Director for Multnomah County Health Department in Portland, Oregon. And I just came back to local public health from running the Office of Equity and Inclusion at the state of Oregon. So I'm really excited about the conversation. And one of the questions that comes up for me is, how much of your work is focused on listening to community with new emerging equity issues, or maybe not emerging, they're historical, but maybe haven't been elevated before, and or implementing wins of prior organizing efforts like the Civil Rights Act of 1964, which I would say probably most health departments are not fully implementing at this point in terms of language access and discrimination in healthcare, et cetera.
You know, we just have a few minutes left, and what I'm going to ask, which is a little bit unusual, work with me here, is for the two remaining people to ask their questions, and then I'm going to have the panel try to respond to different pieces of them. So we'll go over here.
Hi, Ron Bialik with the Public Health Foundation from the disenfranchised non-state of Washington, D.C. I saw Medicaid expansion on the list, which seems to be a no-brainer. The business community typically is supportive. The hospital, healthcare, corporate sector is supportive. The people who need the care are supportive. And it's a very small minority, ideological minority, that seems to keep that from occurring in many states. And as community organizers and health departments working together, what's the way to move that beyond from no to get to yes?
Okay, thank you. And our last question?
I just have a reflection on the matter of violence and the relationship that structural policy has to violence in the United States and elsewhere. If one has ever found themselves in a situation where they are living in an area where there is violence all around them and they cannot get out of it, then it becomes very clear that there are many kinds of structures in place that we often unwittingly not only participate in, but uphold, that support that violence. And I want to respectfully name some of those things. One which is often named is the ready access to lethal weapons, and I mean weapons that are only created to end the human condition. We have to ask ourselves, what part of society benefits from this, and who are those on the periphery that do not? Housing policy. I don't know anyone that wants to live in affordable housing. People want housing that is affordable. And if we think of housing policy in that way, we would design neighborhoods differently. Segregated transit. If we look in many of our neighborhoods, transit is segregated and makes it undignified and unsafe for people and sends messages about who can access what. So those are just a few examples, but we participate in those, we support those things, we fund those things, and we can design them in much more peaceful ways. So that's all.
Thank you for that comment. Okay, panelists, what is your...
I would just respond to our colleague from Multnomah, who we hold in high regard, many of the accomplishments of your department. Remember, everyone, that this is developmental. So we are still, as a discipline, building capacity within our local health departments. So we're doing workshops with our staff. We're helping them understand. We're teaching. We're growing. But we're also trying to figure out where's some implementation traction that we can also get. In our work in Michigan, there are 8 counties working as a part of Healthy Heartlands. Some have targeted to go to the Secretary of State around same-day voting registration. That's the win that they feel like they can take on. Others in Wisconsin are taking on early childhood issues. So even as we're building the capacity, because it's not just our elected officials that don't quite get it, it's still us as a discipline that are learning and understanding what does it mean to do our work through a health equity lens. So it's both and.
There are some issues that are fairly quick wins, potentially, if you do your power analysis correctly. It was fairly easy for us as a city to ban the box. And if you're not familiar with that term, when the employment form has the place for the felony charge right on the cover, if a supervisor has 150 folks that are eligible for that job and they have to figure out how to cut it down to a manageable list to interview, often that just got discarded. So now that's not on there until you get to the final step and you do a background check. And obviously, if you're having an inspector that will be doing child care facilities, if you had a pedophilia charge, you might not want to be hiring them. But for most of the things that they would have a felony, there's no reason not to go ahead and hire. That mass incarceration, all those factors, that's one little piece that you can win on. We banned the ban in regards to, and we had bipartisan support within the state to stopping felons, previous felons or returning citizens that were not allowed to get food stamps or SNAP because they'd had a drug charge. So you can find those. On Medicaid expansion, we've made progress each year. We've gotten closer and closer. This last year, it was really a debate within one party, whereas before it hadn't been. So, we make progress.
I kind of want to speak to both the Medicaid issue and the question about listening for new opportunities versus implementing the win. And I think that they're tied up in the same answer. It's really difficult when you live in a state where businesses have such significant legislative power, when there's no limit on what they can give and how much they can give, to elected officials, it is really difficult to guarantee a structural win on a state level. And we learned that when we were fighting for payday. We've learned it over and over again with wages. And we really need ethics reform in the state if we're going to do anything significant on a structural level. So while there's always new opportunities, new issues, we are constantly having to go back to that question of who benefits and why, and start from there to form our strategy. And the same process goes for Medicaid expansion.
So thank you so much for your patience and for your great questions and comments. I look forward to seeing you all in Phoenix, where we'll have a chance to explore these issues in much greater detail.